Good afternoon, everyone. Thank you for joining me today for another Leadership Dialogue session. I'm Wright Lassiter, and I'm President and CEO of Henry Ford Health, and I'm also the Board Chair for the American Hospital Association. I'm looking forward to today's conversation as we talk about the critical issue of behavioral health, an issue that has only worsened over the last few years of the pandemic. Behavioral health, I think, as we all know, has been long both stigmatized and underfunded. And with the mental health crisis in our country worsening, the hospital field has got to be active in developing and advocating for solutions to help America's citizens who are suffering from and dealing with behavioral health issues, both patients and families, as well as our own caregivers who have increased rates of anxiety, burnout, and sort of resilience drain. And Henry Ford, like many other organizations, we're working to build a stronger infrastructure to meet behavioral health needs in the communities that we serve. Our organization has 3 behavioral health facilities, and we certainly recognize the importance of providing comprehensive behavioral health treatment to improve and expand care and to support patients and families in our community. So in our organization, we provide inpatient psychiatric care, we provide addiction treatment, we provide comprehensive outpatient psychiatric care for patients of all ages, as well as expanding access to services through our virtual behavioral health options. But now let's jump in and let me introduce our guest today. I'm really pleased to have with me today Dr. Matthew Stanley. Dr. Stanley is the Clinical Vice President of Behavioral Health Service Line at Avera Health in Sioux Falls, South Dakota. Avera Health is an integrated health system that serves South Dakota and the surrounding areas in Minnesota, in Iowa, in Nebraska, and in North Dakota through a collection of 37 hospitals, more than 200 primary care and specialty clinics, 40 senior living facilities, in addition to home care and hospice and sports and wellness, home medical equipment, and more. Dr. Stanley has more than 20 years of experience as a psychiatrist at Avera. He's board certified by the American Board of Psychiatry and Neurology and by the American Board of Addiction Medicine. He is the attending psychiatrist for Avera McKenna Behavioral Health Services and is an investigator at the Avera Research Institute. Among Dr. Stanley's many roles, he continues to pursue his interest in chemical dependency through training residents in his field, in supervising the clinical dependency team. In addition, he is assistant professor of the Department of Psychiatry at the South Dakota Stanford School of Medicine. And he is also the chair-elect of the American Hospital Association's Behavioral Health Council. Matt, I would tell you that I know that it was a long intro, but I like to tell folks that when we talk to someone's mother about what's the great things about their son, they give us a really great bio. And so this is the kind of bio that we got for you. And so we're really appreciative of you being with us. I can't thank you enough for joining me today, not only to discuss your work at Avera Behavioral Health, but your thoughts on how we can integrate in a much better way behavioral health along with physical health. So thanks for joining me today.
Well, thanks for having me. I always, like yourself, I find this, of course, it's my life's work, but I find this a topic that we can't discuss enough. And as you said, with everything that's going on in the world today, more relevant than ever. Always been relevant, but I think we're reminded of it daily at this point.
Wonderful. Well, listen, I want to appreciate your time for joining me as part of our Leadership Dialogue session. And let's just jump into some questions. The best way to do this is just to, we'll start diving in and have a good conversation. So let's start with where things always seem to have to start over the last couple of years, and that's with COVID. Clearly, as we look back over the last 2+ years, let's sort of talk about the impact that COVID has had on behavioral health and what trends you've seen in the communities you serve, and how they've underscored the general need for enhanced behavioral health services in America.
Yeah, it's been a lesson every day and continues to change for us. There's both kind of the anecdotal clinical experience we've all kind of been in touch with, and then we're starting to see more and more research that comes out and either validates what we thought or even opens our eyes to new concepts. For instance, the WHO just put out a new scientific brief that indicated worldwide anxiety and depression were up 25% across the world. So, that's that's the magnitude of change that indicates is remarkable.
Mm-hmm.
Clinically, what we've seen, it probably like you in Detroit with Henry Ford, we had a lull there for about a month or two at the very opening of the pandemic. And since then, at least in behavioral health, and I think the rest of the hospital as well, it has been floor to ceiling, wall to wall. We have had more patients than we've had beds for, providers for. It has literally been, becoming more creative, trying to find more ways to support people, finding ways to treat people even outside of the hospital. And I think we see that, and we kind of understand it in those that were at risk of COVID and in adults who lost their job. I think the wave that we've seen in behavioral health that maybe wasn't so apparent or anticipated is the impact it's had on our children, our adolescents.
Okay.
We have been incredibly impacted in the adolescents. Again, we've never seen numbers like we are seeing now. And again, the data tells us, the increases in children, the depression and anxiety, it's again, 25% increases across the board. We're seeing increased ER visits, well over and above what we've seen historically. More thoughts of suicide. If there's the only somewhat promising piece, or at least a better piece, we haven't seen the tremendous rise in suicide events, although we were already, unfortunately, in the midst of an epidemic there.
Right.
And so we haven't gained ground. We just didn't lose ground any faster, if you will.
Sure.
And then the overdoses. The other thing, I think, the substance use, the impact COVID, the isolation, so much of substance use and recovery is about a community approach. That was lost to many. Mm-hmm. Substance use, as we know from sales of alcohol and other indicators, only went up during the pandemic. And for the first time, we have had over 100,000 deaths in the preceding year in overdose alone. So all of these numbers are frightening, and
sure.
We're treading new ground every day with the pandemic, and so what that bodes for the future, I think, is very hard to project at this point.
Got it. Well, I really appreciate you sharing some of the data around the rise in stress, anxiety, and other conditions, and the impact on adolescents. I think it's just something that many of us know anecdotally, and then when we begin to hear statistics, it helps you hardwire even more clearly the challenges that our country's facing. So let's talk a little bit about hospitals and health systems. I mean, certainly we know that we play important roles in behavioral health care, and whether it's in our own facilities with our caregivers and team members, or the community members that we interface with outside the four walls, trying to help them connect with resources that might be available in their community. Are there new ways, as you think about what's happening today, are there new ways that hospitals and health systems should be looking to support and increase access to behavioral health services across the health continuum that you might want to share with our listeners?
Yeah, I think we've all become more aware, more in tune with the use of telemedicine. As we all kind of know, that just took a tremendous leaps, and it had been used very effectively in behavioral health even prior to the pandemic, but we increased that use by leaps and bounds. So that I think that continues to provide the greatest hope for reaching more people. A couple of just personal observations. We run a fairly large telemedicine outreach clinic, and we have some contracts with some impoverished areas and very geographically remote. You mentioned I live in South Dakota here, and we serve a 5-state area. And so we are very geographically challenged. We often have 3-4 hours of a drive just for a patient to get to a provider, particularly a specialist. So one of the lessons learned was we had contracts with some of these remote areas, relatively impoverished population. And we had very high no-show rates prior to the pandemic. In part, as we look back on it, lessons learned, that was because that patient had to drive to a facility in order to complete the telemedicine appointment. With the CARES Act and the ability to go direct to the consumer. So now they could talk to us on a smartphone. Now they didn't have to find someone to watch their child. They didn't have to pay for gas. They didn't have to find somebody to give them a ride. We actually saw our completion of appointments rise dramatically. So it really made everyone rethink some of the biases that they had. You know, I think there was the belief that it just didn't matter as much to these folks, or they weren't as committed to their care, none of which I think is true. I think, you know, we were just underestimating the limitations, the barriers that these folks had to overcome in order to get to their appointments. So that's been a tremendous, I think, enlightenment for us. And within that, a great opportunity. I really, you know, we've really been advocating that the direct to consumer piece of mental health care is continued. And at this point, it looks promising. And I know we still have continuation, but I think that's a critical component. You know, there's other things that have been, I think, successful for health systems. The hospital at home, not so much, I think, in, you know, behavioral health patients, we're a little different. Mostly the only reason you come into the hospital is if you're a danger to yourself or others. That's kind of that typical criteria. So it's very hard to keep someone at home when those are the concerns. But I think where the opportunity for behavioral health is to integrate with the other hospital at home components. Because when we look at things like chronic conditions and containing the, you know, creating wellness there and containing the cost and the morbidity, that behavioral health component is incredibly important. People that are depressed or anxious, you know, they're not able to be as compliant. They're not able to function as well. Obviously, their quality of life isn't as good either. So I think those are a couple of the opportunities for us that really jump out from this pandemic experience.
Got it. I appreciate that. And I would tell you, as you talk about the continuation of support that's necessary to fund and provide appropriate reimbursement for behavioral health to be delivered directly to consumers, that's certainly something that the American Hospital Association is working very hard in Washington to advocate for and help people understand the value of that. So certainly appreciate that. You know, Matt, as we were doing research about all the great things you all are doing in South Dakota and more broadly at Avera, we learned a bit about behavioral health urgent care service program that you all have created. Can you just tell us a bit more about how that's operating and the impact that's having on service provision and on the outcomes that you all are trying to affect in your region?
Absolutely. Yeah. Very happy to talk about it. So urgent care is a little different than maybe we're all familiar with urgent care at the primary care kind of level, the level below an emergency room. But we went specifically to behavioral health to create an urgent care to try to improve a couple of, I think, chronic problems. One is access to care. In behavioral health, and quite honestly, I think we've all said it, we'll never have enough psychiatrists to meet all the needs out there. But folks still need to get somewhere to get care initiated. I think the other thing that's difficult in behavioral health care is that it's hard to navigate behavioral health. It is a more fractured health delivery system than most. And primary care is still a great point to start, but a lot of patients aren't comfortable with that. Right. So with the urgent care, we have essentially created a walk-in opportunity, very different than an emergency room. It's designed to be friendly to patients that are going through an emotional crisis, often have family members with them, quite frankly, often are brought in by police in our urgent care, or brought in by transport from another facility. And it is staffed then by master's level counselor, a nurse, behavioral health techs, and then advanced practice providers in healthcare.
Okay.
So the idea is to give you a very comprehensive evaluation, just like you get in an ER. We're not called an ER because we don't do trauma and some of those things.
Right.
But it's the idea that here's this opportunity to walk in, get a comprehensive evaluation, get you placed at the right level of care. So some of these patients will go directly into the hospital from urgent care. We also have a crisis stabilization unit attached to that. So that's a 23-hour observation level of care. Okay. For folks that are somewhere in that gray zone, don't quite need to go into the hospital. You know, it's attached to our partial hospital program, so we can refer them to a day hospital. So essentially, right, what we've tried to do is build out a full spectrum of care and have a single entry point to help consumers navigate and get to the right level of care at the right time for them to really kind of resolve their behavioral health issue.
Got it. Makes sense. We really appreciate that explanation, and just certainly applaud Avera for the work that you all are doing, for what you all are leading in the communities that you serve. You know, you used the I word a couple of times in the last conversation, and so let's just maybe talk a little bit about that I word. And people might say, well, what's the I word? And that word's integration. And there's so many ways you can talk about integration of healthcare services, but I think historically we all acknowledge that there is a bit of a disintegration currently between behavioral medicine and physical medicine, but yet all the research that you see would suggest that we need to do a better job of integrating physical and behavioral medicine. I think you've talked a little bit about that with some of your prior answers to questions that I posed, but just anything else you want to talk about in terms of the opportunity for us to do a better job of integration between behavioral and physical medicine that might be useful for our listeners?
Yeah, well, I appreciate you bringing it up, because I think it's probably the most critical thing that we need to focus on over the next several years. And it's been such I think that artificial dichotomy that somehow there's a difference between mental health and physical health. You know, it's been so damaging, I think, to the behavioral health world, but also physical health for years. And as you said, you know, all our evidence, all our scientific foundation indicates, you know, the human body is one living organism that involves both behavioral health and physical health, if you even want to use those terms. But I think several things. I think one of the reasons that we struggle so much with access is across the country, we don't have an acceptance that behavioral health should be a part of your medical care, should be addressed with your primary care physician, should actually be a component of every time you touch base with your healthcare provider. And I think until we overcome that, now some people do it wonderfully, and some systems have addressed it very aggressively, and I think they're reaping the benefits. But we still struggle with that, and you know, its effects are kind of insidious. I think everything you mentioned, reimbursement. I think because we're somehow seen as a different branch of medicine, there's often reimbursement issues. I think it contributes to stigma, the fact that often it's something you wouldn't even bring up in your primary care office because you're embarrassed, or they act like they don't want you to mention that here. That's not what we treat. So there are a number of challenges there. But in order to get a handle on you know, the things we're talking about, increasing suicide rates, substance use rates, increasing depression and anxiety, you know, it really needs to begin with our primary care partners, and really has to be pervasive throughout every level of our healthcare. You know, I did mention that you know, there's significant data that indicates if you're managing any chronic disease and you're not concurrently managing a behavioral health issue, your costs and patient outcomes are going to go in the wrong direction. So there's both, I think, societal repercussions and I think, healthcare repercussions if we don't focus more on integration. Now, I think the difficulty, the trick is, kind of choreographing the move between back and forth between primary care and behavioral health and making sure the right access points and supports are available. So those are, that's one of the challenges, but I think primarily we need to just accept this as medical disease of the brain, if you will, and move forward.
Great. Well, let me just pose one last question to you, because we try to keep these dialogues to a manageable level so that our listeners have a good session that's not too long. And you talked a little bit previously about reimbursement and the challenges that exist there. And I think we would all acknowledge that there's been an inadequate reimbursement framework for behavioral health services. And in addition to that, there's been a shortage of necessary personnel to deliver the services that many citizens across the country need. And so clearly over the last couple of years, that probably has gotten worse in some ways, even though we have had enhanced reimbursement for things like telemedicine and video connection directly to consumers. But there's not necessarily been a fundamental change in the reimbursement for behavioral health services per se. So maybe just talk a little bit about, from your perspective, how inadequate reimbursement has driven some of the trends that we see in both shortage of both clinical personnel, behavioral health workers. How does this dearth of reimbursement contribute to the inequities that we see in many communities related to the provision of behavioral health services and frankly the ability of individuals to live their best selves?
Well, I think you identified it. I think the lack of reimbursement has led to some of our workforce issues. Now, workforce is difficult across a number of professions at this point in time, but it's been years since we have had an adequate number of mental health providers. And there's some frightening statistics out there. I think more than 50% of all psychiatrists are in the last decade of practice. So this, rather than this improving, there's real potential for it to become worse. I think the other thing that we maybe underestimate is, healthcare systems have to pursue a margin just to stay operational. Although we're nonprofit, we're mission driven. We are trying to do the right thing for the patients and for our employees. But we still have to pursue, where the dollars are in order to keep the doors open. And so, chronically underpaying or, limited reimbursement for behavioral health has led to issues like not enough psychiatric beds, no new facilities being built or very few facilities being built, a reduction in, I think, in people interested in going into mental health. One of our biggest struggles right now are nurses that are interested in and trained in behavioral health. So even when we can get providers and have beds, we're sometimes challenged with staffing. So I do think that is a tremendous challenge for us. It's not something that will turn around immediately. It's going to be several years, even if we get get equities in payment. It will take a while to turn that ship. But I can't tell you how thankful I am that the American Hospital Association has put their weight behind this effort and recognized it as an issue that needs to be addressed.
Great. Well, Dr. Matt Stanley, I appreciate you joining me today and sharing perspectives. I really enjoy these leadership dialogues, but what I find is that we could always spend another 30 minutes talking about more issues related to the topics we have. But I appreciate you sharing insights around behavioral health, around the successes that Avera is having in addressing the needs that you all are serving in your 5-state community, and how we can best support behavioral health services, behavioral health providers, workers, and how we can integrate behavioral health into whole person care. So very appreciative of that. I know this topic is one that can benefit all of our listeners, whether they're in the behavioral health field directly or in more broadly in hospital and health services. I encourage anyone who's struggling with feelings of anxiety or depression, to please reach out to those who can provide support for you so that you can get the services that you need. I would also just say to our listeners that you can tune in to visit AHA.org and the AHA's Physician Alliance website for additional resources that are focused on stress, coping, and mental health for healthcare workers. And until next time, I thank you for joining us for today's Leadership Dialogues. I hope you're back for next month's Leadership Dialogues. Thanks very much.